Hi, everybody. I'm Erica Mayer from Dana-Farber Cancer Institute in Boston. I'm going to be speaking today about advances in the care of patients with hormone receptor-positive, HER2-negative metastatic breast cancer and an update for 2023. So just to get started, what a year it has been. Mirroring what we've seen in the rest of medical oncology, breast cancer has been an incredibly fast-paced field. We have many new agents, new drug approvals, lots of evolving data to stay on top of. And the new drug approvals and these new results means that our treatment paradigms are continuously in evolution and under modification. I do think that toxicity and tolerability have become really key and maybe differentiators among all of the agents that we are now looking at. And the new findings that we're going to talk about hopefully result in better and longer outcomes for our patients. So let's jump in. So first, we're going to be looking at hormone receptor positive disease. And we saw updates from the Monarch 3 study. Monarch 3 is one of the first-line studies looking at endocrine therapy with or without a CDK4/6 inhibitor. In this study, the CDK4/6 inhibitor is abemaciclib. This is one of the studies that's been previously presented, and what was shown at San Antonio from Matt Getz was an overall survival update. Notably in this study, this was a 2-to-1 randomized study, so 2/3 of the patients received abemaciclib and aromatase inhibitor, 1/3 placebo and aromatase inhibitor. And the study enrolled a total of about 500 patients. This is first-line setting. What was seen in the final overall survival results was that the patients who received the abemaciclib had a longer overall survival, 66.8 months, at what is now about 8-year follow-up on this study. And that's in comparison to the control arm of 54 months. So numerically, this is longer. It's more than a year longer. However, this did not meet statistical criteria for the study, which was fairly rigid and stringent due to the specific design of the trial. The prolonged overall survival was also seen in the subgroup with visceral disease, which tends to be a group that we think of in particular for use of abemaciclib. I'll also point out that they presented updated progression-free survival, and this continues to be dramatically longer with the use of abemaciclib, about 30 months compared to about 15 months, so a doubling. And if you look at the curve on the right, the red line, I think a very interesting observation is that at this 8-year point, about 23%, so about 1 in 5 patients are without evidence of disease progression. And these are patients who started therapy, on average 8 years before. I think we all have these people in our practices who started CDK4/6 inhibitors around the time of initial approval and continue to do extremely well on the drugs. So I really think that speaks to the power of CDK4/6 inhibitors when used in the first-line setting. If we put this into context, these are all of the randomized trials using CDK4/6 inhibitors in the first-line and pretreated setting, looking at overall survival outcomes. We can see that the trials with palbociclib, Paloma 2, Paloma 3, unfortunately did not have an improvement in overall survival. The trials with ribociclib, the Mona Lisa series, all did have a significant improvement. And we can put Monarch 3 into context here, that this did not meet statistical significance. But I think it's really interesting, again, to look at the numbers. With that improvement of 13 months from 53.7 to 66.8 months in Monarch 3. If you look one line down to Mona Lisa 2, a study with a very similar design, just using ribociclib, we can see that the numbers are almost identical, about a 13-month improvement. And so, it's interesting to think about, we see very similar activity, very similar improvement, and yet the statistical significance is a little bit different. And this ultimately may reflect trial design and not so much the specific agent. I'll also point out that we did see at San Antonio this year a rapid update of a study called Parsifal-Long. This was a study that was with palbociclib in the first-line setting using palbo with fulvestrant or palbo with AI. And there was no difference in the arms for the original Parsifal study, but they combined them to do long-term follow-up. And they presented that data at San Antonio. The median overall survival in that study was 65 months. Gosh, that's pretty similar to what we see in Monarch 3 and Mona Lisa 2, quite different than what was seen in Paloma 2, which was the official first-line study. And from my perspective, I think that just speaks to a lot of the variability in statistical design and power that exists among all of these trials, making it really hard for us to know exactly with precision what are the relative benefits. That being said, I think we still continue to see a lot of activity from abemaciclib from the Monarch 3 update. And so, in summary, for Monarch 3, again, this is a smaller trial than the other first-line trials. It had a different statistical design, including the 2-to-1 randomization, and this presents some statistical challenges versus the other larger trials and some power issues, particularly with long-term follow-up. We also know whenever we look at overall survival, benefits can be washed out with subsequent therapies, and that, again, weakens power. But I do think it's really neat to look at this 1 in 5 patients without progression at 8 years. I think that really speaks to the power of the drug. And the Parsifal long data makes me think about palbociclib as another option, which some of us may not be using that much now after that Paloma update from last year. For the time being, I think many of us are selecting ribociclib as our CDK4/6 inhibitor of choice in the first-line setting, given the positive overall survival benefits with that drug. But I find that Monarch 3 update is not making me think any less of abemaciclib. I think this is a reasonable alternative, particularly if ribociclib is not feasible in the setting. So let's move on now. And we're going to talk about other updates from another exciting study, Capitello 291. So Capitello 291 is looking at a drug called capivasertib, which is an oral AKT inhibitor. This was a study in pretreated patients with metastatic hormone receptor-positive HER2-negative disease who had had up to 2 prior lines of endocrine therapy, and they wanted at least half the patients with prior CDK4/6 inhibitor therapy. I'll point out just a few important details. So patients in the study were randomized to capi and fulvestrant or placebo and fulvestrant. The capi dosing is 400 milligrams twice a day. Now, this has an interesting dosing pattern, 4 days on and 3 days off. And this is intentional to help avoid buildup of side effects and toxicity. I'll also point out that in the eligibility, patients were allowed to enter with diabetes, not requiring insulin, and with a hemoglobin A1C less than 8%. And this is different than the trial Solar 1, which is for the other agent that targets the PI3 kinase AKT pathway, which is alpelisib, which did not allow patients with diabetes into the study. So this is more flexible in terms of the eligibility. All right, so let's look at what we found in the study. So the primary endpoint was progression-free survival in the overall and in the AKT pathway altered population, which was about 40% of the patients who entered the study. In the overall population, there was an improvement in progression-free survival, 3.6 months to 7.2 months, hazard ratio 0.6. And in the AKT altered population, meaning an alteration in PI3 kinase, AKT, PTEN, there was a similar improvement, 3.1 to 7.3 months, and an even more favorable hazard ratio of 0.5. And based on the strength of these results, this very recently led to the approval of capivasertib in combination with fulvestrant in patients with an AKT pathway mutation. This approval just happened around November of 2023. So that was fairly recent at the time of this recording. So we are just beginning to bring capivasertib into our clinics. Regarding the side effect profile, notable side effects included diarrhea and rash compared to the control arm. And I'll point out that a vast majority of patients experienced some grade diarrhea. About 10% experienced grade 3 diarrhea. The rash numbers here are maybe a little bit of an underestimate because there are other categories for skin alterations that could be included. And so the rates of rash may be a little bit higher. We do know that a number of patients had to take either topical or even oral steroids to manage rash. And so that may be more of a toxicity issue. But I'll also point out hyperglycemia rates were low. And remember, this was a trial that allowed patients who had diabetes or an elevated hemoglobin A1C to enter. And even with that more broad population, rates of hyperglycemia were 16% all grade and only 2% with grade 3. Very different than what we see with alpelisib. And so we know that there was more dose holds and dose reductions in the treatment arm, but only 13% of patients had to discontinue for adverse effects. I'll also add that unlike some of our efforts now using prophylactic medicines, there were no mandated prophylactic medicines as part of the Capitello study. And if one perhaps used prophylactic, for example, prophylactic antihistamine, maybe the rates of rash might be lower. So we did see an update at San Antonio looking at outcomes based on the specific AKT, PI3 kinase, PTEN mutations. And in that subgroup of patients who had a mutation, this was looked at based on whether the mutation was PI3 kinase, AKT, PTEN, or if they had different combinations. And very reassuringly, the benefits of capivasertib were maintained across all of these groups. So if you have a patient who has, let's say, an AKT mutation, but not PI3 kinase, and you're wondering, will I get the same benefit? The answer is yes. Or if they have PTEN, the answer is yes. So I find this very reassuring that as we look at our genomic testing, and if we see these mutations, we know that no matter what the mutation, we can still be offering capivasertib. So the summary for capivasertib is that this combination is now an approved therapy for pretreated hormone receptor positive HER2 negative disease with a mutation in the PI3 kinase AKT-PTEN pathway. Now, you need to know if your patient has this mutation, so you need to get tumor genomic profiling. Many of us are getting this at baseline using a tissue assay, but we can also be getting it with ctDNA. This performs extremely well to provide this information for us. And I think as we consider the agents that target this mutational pathway, the toxicity profile can be a differentiator. Capivasertib can cause diarrhea and rash, to a lesser extent, nausea and fatigue, but importantly, less hyperglycemia than what we see with alpelisib. And as I'm offering this to patients, I'm thinking about giving prophylactic antihistamine to help prevent that rash and telling patients to use antidiarrheals aggressively if they begin to have diarrhea. So I am now sequencing this before I would be offering a patient alpelisib.
So I'm just kind of curious whether or not this kind of intermittent, 4 days on, 3 days off schedule has been looked at with alpelisib.
I'm not aware of efforts to look at that intermittent schedule with alpelisib. I think most of the efforts to prevent and manage toxicity with the drug have been built around appropriate patient selection and use of prophylaxis. For example, there's a study called Metallica that looked at using prophylactic metformin for a week before beginning alpelisib, and that study showed a lot of success in reducing rates of grade 3-4 hyperglycemia. Now, we do know that metformin can cause some diarrhea, and so it's a little bit of a trade-off there. But that dosing schedule has not been looked at. I will say that it's one thing to be in a trial and have patients being watched very closely to use that dosing schedule. It's another thing to have real life patients, some of whom struggle taking a daily medicine once a day and what we think of as the most easy way to take a drug, learning how to take it intermittently. So we're going to have to use all of our resources in clinic, all of our patient education resources to make sure that patients take the drug in the correct schedule. Otherwise, they may increase their risk of toxicity.
Yeah, I heard Adam Brofsky, I worked with him a few weeks ago. He said he tells his patients, take the weekend off. But I think 3 days off, that's not going to be, I think that could be a problem. Have you seen that as an issue so far, or too early to say?
Yeah, it's a little, I think it's a little early to say because we've only had the drug available for like 6 weeks, but at the time, right today. But, what we're doing at Dana-Farber is, using our pharmacists who do drug education, our APPs who do drug education, and, we're probably going to do a lot of direct outreach to patients to check in with them and make sure, are you taking it properly? I also hope that there can be a way for the drug to be dosed in blister packs, which I think is a much better way for people to keep track of what they're taking than just in a bottle.
Right. Yeah, that's a great idea. Yeah, because it's hard to think of another situation like that. I'm trying to think of another drug in oncology. I'm sure there are. I just can't think of one right now. But anyhow, yeah, that's very interesting.
Yeah.
All right, whenever you're ready, please continue.
All right, let's move on. So one of the real hot topics at San Antonio this year was a late-breaking presentation of the INAVO120 study. INAVO120 studies inavolisib, GDC0077, which is an alpha-specific PI3 kinase inhibitor. This was a study looking at a triplet. The study enrolled what I would consider very high-risk, first-line, hormone receptor positive, HER2 negative patients whose tumors have a PIK3CA mutation. Now, I call this high risk because these were patients who progressed during or within 12 months of completion of adjuvant endocrine therapy. So these are the patients recurring on their aromatase inhibitor where you are really quite worried about endocrine resistance, plus they have a PI3 kinase mutation. So these patients were randomized to receive a treatment arm of inavolisib plus palbociclib plus fulvestrant versus placebo plus palbociclib plus fulvestrant. So palbociclib, fulvestrant, a very reasonable first-line option for these patients compared to a triplet, which is a little unusual. We don't use too many triplets. And what was shown in the study was that for the primary endpoint of progression-free survival, there was a significant improvement from 7 months to 15 months with a hazard ratio of 0.43. So close to a 60% improvement in progression-free survival. So this is a positive study. I will point out that when we look back on the first-line studies of CDK4/6 inhibitors, our improvement from the placebo to the treatment arm tends to be more in the range of like 12 months to 24 months. And here we see the lower numbers. And I think that speaks to the high-risk nature of this population, and that when there is a PI3 kinase mutation, these cancers can be more resistant at baseline. But even in this more resistant group, we are seeing a benefit. I'll also point out that if you look at the very beginning of the Kaplan-Meier curve for the control arm, there's a drop-off that happens pretty quickly. We avoid that with the use of the triplet. So, a lot of activity seen there. Regarding side effects, the inavolisib does cause several side effects, including stomatitis. We do see some rates of hyperglycemia, although perhaps not as much as we see with alpelisib, some diarrhea, nausea, rash. This is typical for an alpha-specific PI3 kinase inhibitor. But in general, I would say that this was a relatively manageable toxicity profile. And, when we think about toxicity when we use triplets, this is where some of the triplet studies have not been able to move forward because of excessive toxicity. This study was manageable and able to complete. And I think that speaks to palbociclib as an ideal candidate for combination, since of the CDK4/6 inhibitors, it tends to be a well-tolerated drug. I'd also point out that there was no toxicity prophylaxis used in the study, so rates of these toxicities might be better if some prophylaxis was used. So very reassuring to see outcomes improve in a very high-risk cohort of patients. This, again, shows us that we need to know the PIK3CA mutation status from the time of diagnosis. So when we are getting that baseline biopsy or blood work to confirm the patient has metastatic disease, we need to immediately get tumor genomic profiling to know if PI3 kinase mutation is present. And, palbociclib is a CDK4/6 option for metastatic disease, and I think it's really an ideal partner when we're thinking about triplets. There was a very nice discussion of this data from Hope Rugo at San Antonio, and she pointed out some features of the patient population that are unique, including that this was a very tightly regulated patient group. They had a low BMI, there wasn't a lot of diversity in the group. And considering the hyperglycemia and mucositis that was seen in the toxicity profile, this might be different in a more real-world group of patients, particularly where there's a greater range of BMI. Additionally, we do have a whole new generation of mutant-specific PI3 kinase inhibitors that are really designed to target the mutant PIK3CA and not wild type, and dramatically reduce rates of hyperglycemia. And that's really going to be the next generation of where we're going with these drugs.
So a couple quick questions. How much second line and beyond data do we have on inavolisib?
At this time, not a great amount. There are other studies that are looking at this drug, not only in hormone receptor-positive disease, but also in HER2-positive breast cancer, where patients who have PIK3CA mutated tumors also have somewhat inferior outcomes. But we're just starting to learn more about how this drug performs.
The other thing that's almost shocking is it looks like there's the control group had an 80% relapse rate in 18 months.
I think that red curve, the control arm here, really speaks to how this is a high-risk group. When a little earlier when we were talking about Monarch 3 and how we can have 1 in 5 patients being disease-free at 8 years, that's one of our more favorable hormone receptor-positive groups of patients. This is the flip side of that. This is really our most bad actors. And we can see that these patients are really not doing very well. And so the idea of escalation to a triplet makes sense.
I mean, that's kind of amazing that kind of prognosis, 80% relapse in 18 months.
Yeah, I think, when we consider hormone receptor positive disease as a group, it's our largest subset of metastatic patients, and it's really heterogeneous. And, anyone who's in clinic knows this because you have patients where the path report looks somewhat similar and yet dramatically different outcomes. But I really think tumor genomics here is beginning to unlock this for us and help us from the jump identify the bad actors and escalate when we need to. And then, on the flip side, identify people whose disease is more latent and more indolent, where something like this would not be appropriate. So, I think this really will help us much more with treatment tailoring.
Just kind of curious right now, if you could, would you use this strategy?
I find this data very compelling, and I think exactly as you point out, the inferior outcomes with the control arm. We see this in clinic. We see these patients where we are really hoping they're going to get years of disease stability on their first line CDK4/6 inhibitor, and they don't. And it's very discouraging for us as providers and for our patients. And so if I know that my patient would be on that red line, and I know I have a way to help them do better and have, over 50% improvement in progression-free survival, keep them going twice as long on their agent, I would absolutely do this. But I think that, the toxicity profile is significant. And, this, again, it was a very tightly regulated population. I think we need more information about how to prevent and manage the side effects so that patients can comfortably stay on this and have a good quality of life.
I wonder what you do with your patients who are not PIK3 positive in that situation.
Who have resistance but no PI3 kinase mutation. Yeah, I think right now our plan is to give first-line endocrine and CDK4/6 inhibitor, but as we'll talk about in a moment, we're going to be looking for other resistance mutations and other strategies that we can use. So and speaking of that, let's move along to talk about a whole new category of drugs, the oral SERDs. And we saw some updates from the Emerald study, which is a phase 3 study that's looked at the oral SERD elacestrant. This was a trial for pretreated patients, all of whom had had prior CDK4/6 inhibitor, hormone receptor positive HER2 negative disease, randomized to elacestrant monotherapy or endocrine therapy of provider choice. Patients who were enrolled in this study were very, I would say, real world. All of them had CDK4/6 inhibitor, about 70% with visceral metastases, about 20% with a line of chemotherapy. So it really does resemble what we see in clinic. The overall study for intention to treat was a positive study. But I think the better way to look at the data was an updated analysis in patients who had an ESR1 mutation, looking at the duration of prior CDK4/6 inhibitor. So outcomes were more significantly positive in patients with an ESR1 mutation, which we'll talk about in a moment, is a preferred mutation for oral SERDs. And as we can see from these figures, patients who had longer duration of time on their prior line of therapy, which had CDK4/6 inhibitor, had greater benefits from the use of elacestrant. In particular, patients who were on for at least a year beforehand had an improvement in their progression-free survival from about 2 months on the standard of care endocrine to close to 9 months with elacestrant, hazard ratio 0.4. And so I think as I consider use of elacestrant in my clinic, I find this data very helpful. And it's not really about the CDK4/6 inhibitor here. It's really about endocrine sensitivity. If a patient was on their prior line of therapy for at least a year, that's indicating that their disease is endocrine sensitive and they are more likely to respond to another line of endocrine therapy. So I think this is a very helpful way for us to identify best candidates. The drug is approved for pretreated patients whose cancers have an ESR1 mutation. And so we saw updated data at San Antonio this year looking at biomarkers and subgroups. So they looked at the patients who had ESR1 mutations as well as an additional feature. And I highlight here 2 of the categories that I think are particularly helpful. First of all, I'd just say that all of the patients demonstrated benefit from the use of elacestrant over standard of care. These are all the patients with ESR1 mutations who had had at least a year of prior CDK4/6 inhibitor in their prior line of therapy. Now, patients who have both ESR1 mutation and PIK3CA mutation did have a benefit from about 2 months to about 5.5 months. So elacestrant was active in this group and provided benefit. You'll notice that 5.5 months seems to be somewhat less than the other categories that were examined here. And that again speaks to the underlying resistance of patients who have cancers with PIK3CA mutations. But I find this very helpful because if I have a patient who has both mutations and I'm wondering, should I offer that patient elacestrant or should I offer that patient something that targets the PIK3CA, be it capivasertib or alpelisib? I feel comfortable offering elacestrant in that situation, particularly if the patient has perhaps lower volume disease, no visceral disease, has somewhat more latent disease. Then I think it's very reasonable to offer elacestrant. If the patient seems to be in more of a impending crisis situation, then endocrine with targeted agent may be a preferred choice. But I think this is very helpful to manage those patients. Additionally, for patients with ESR1 mutation and HER2 low, we see a real nice improvement 2 months to about 9 months with elacestrant. And again, suggesting here there's no reason if they're HER2 low to start thinking about TDXD in this setting. We can stay with endocrine therapy. So I think this is very helpful data. The Emerald update is that elacestrant monotherapy is an option for patients with hormone receptor-positive metastatic disease and an ESR1 mutation and who have retained endocrine sensitivity, which we can identify based on how long they were on their prior line of therapy. In that situation, the ER pathway is still the driver of disease, even if there is coexistence of another mutation or HER2 low. And so we can use this to prioritize elacestrant before the other options. I think that's really nice because elacestrant is a very well-tolerated agent. Now, I would love to use elacestrant in combination with a targeted therapy. There are studies, for example, the Elevate study is looking at these combinations, so we await this data. And a very important thing to note is that ESR1 is a kinetic mutation. This develops over time, and this means that we need to check the ESR1 status at the time of progression in patients with metastatic hormone receptor-positive breast cancer. Now, we know this from a variety of experiences looking at the rates of ESR1 mutations at different time points in treatment. We know that patients in the first-line setting, for example, the Mona Lisa 2 patients, have a very low rate of ESR1 mutation, just 4%. But in studies looking at pretreated patients, that rate is much higher, somewhere between 25 to 40%. So this is a mutation that develops over time. It's kinetic. And that means that we can't just check at baseline and not check again. We have to check continuously to know if that mutation is developing. Additionally, how do we check? Well, we really do think that liquid biopsy or ctDNA would be a preferred way. If you look on the left, you can see that if you compare looking for ESR1 based on tissue or based on liquid, the purple bar in the ESR1 column indicates where there's discordance between tissue and liquid, where the tissue is negative and the liquid is positive. So ctDNA is a better way to look for ESR1 than doing a biopsy. And another reason why it's good is that, as we know, cancers are not homogeneous. They're not the same throughout the body. There's heterogeneity, and this can include that different parts of the cancer can have different resistance mutations. ctDNA is looking at the whole cancer. It's an overview as opposed to like a liver biopsy, which is only looking at the liver. So it really is the best way to provide the overview. And this year we did have an update, a rapid FASCO guideline update that Hal Burstein and his team published, looking at how best to treat hormone receptor-positive, HER2-negative disease, recommending routine testing for ESR1 mutations at time of recurrence or progression on endocrine therapy. We should do tissue testing or blood testing at the time of progression because the ESR1 mutations develop over time. And importantly, that if you test again at time of progression and the ESR1 mutation is not there, you're going to check again in the future. We just have to continue doing it. And I think a paradigm shift for all of us is building this into our framework of how we take care of patients and knowing that we have to do this routine testing. So Why is this important? Well, we know we have this category of therapy called oral SERDs, and we know that these are agents that are particularly helpful in the setting of an ESR1 mutation. They can bind to the mutated estrogen receptor, not only blocking estrogen ligand stimulation, but they also can lead to degradation of the estrogen receptor, so can be more potent than other therapies. And we don't just have the oral SERDs, but we have oral SERM, such as lasofoxifene, and the exciting agents in the PROTAC and CERAN category. So we have a whole collection of new endocrine agents which are currently in development. Let's just take a look at some of the ones that are in development. So we have seen recent updates of the SERENA-2 study. This is a trial that's looking at the oral SERD camizestrant. This is a phase 2 study that enrolled pre-treated patients to be randomized to get fulvestrant monotherapy or different dose levels of camizestrant, 75 milligrams or 150 milligrams. There was a higher dose, 300, and that closed early. The study population, again, I would describe as real world in this study. About half of them had prior CDK4/6 inhibitor, about 60% had lung or liver metastases. And if we look at the intention to treat results for progression-free survival, patients who received camizestrant had an improvement in PFS compared to those who received fulvestrant monotherapy, from about 3.7 months with fulvestrant to about 7 months with a camizestrant arm, with a hazard ratio around 0.6. So camizestrant outperformed fulvestrant in the pre-treated setting. And specifically, if we break this down by whether the patient had an ESR1 mutation detectable at baseline or not, we can see that the benefit here is really driven by the cancers with the ESR1 mutation, where we see an improvement from 2.2 months to as high as 9 months with camizestrant. In the ESR1 wild type population, we really don't see a significant difference among the arms. And so we saw updated data at San Antonio this year looking at outcomes in patients who had one ESR1 mutation, more than one mutation, or specific mutations, including the D538G or Y537C mutations. And if you can see these Kaplan-Meier plots, you'll see that there is a preserved benefit of camizestrant in all of these populations over fulvestrant. So camizestrant monotherapy has shown promising data over fulvestrant, particularly in those with an ESR1 mutation, and it doesn't matter which mutation or how many mutations are present. So there are many ongoing studies with camizestrant, including looking at combinations. There's other studies looking at other oral SERDs, including giredestrant and imlunestrant, which we're going to take a look at. And then we also have the other agents, the PROTAC ARV-471, and the oral CERAN OP-1250, which have also shown some really exciting new data. So overall, I think this is going to be a very rapidly expanding space in the next 1 to 2 years. We're going to see a lot of data coming out for these novel endocrine agents. And just to sort of take a bird's eye view, you can see that there are many trials going on with all of these agents. And I'll actually point out in red are the very large randomized adjuvant trials which have launched. With giredestrant, we have lidERA. With camizestrant, we have Cambria-1 and Cambria-2. And with imlunestrant, we have EMBER-4. And these are trials that are designed to capture tens of thousands of patients. So we have a lot more data coming out about these agents in the next few years. So now let's turn to imlunestrant, and we had updates of the EMBER study from Kamal Javeri. This is a multi-armed study, and we saw updates looking at imlunestrant monotherapy as well as combinations, imlunestrant and abemaciclib, and even a triplet of imlunestrant, abemaciclib, and aromatase inhibitor. And the randomized portion was in patients who are less heavily pretreated, no more than one prior line of therapy for advanced disease, no prior CDK4/6 inhibitor. And here are some waterfall plots looking at these groups. First on the left is the imlunestrant monotherapy at the recommended phase 2 dose. This is a population of patients who is more heavily pretreated, prior endocrine therapy for advanced disease, prior CDK4/6 inhibitor. And the response rate in this group was 12%, clinical benefit rate 55%, PFS 7.2 months. 7.2 is very respectable. We've seen PFS post-CDK with fulvestrant in the 2 to 3 month range. We just looked at that. And here, 7.2 months is really quite robust. So that's a very nice efficacy signal. In the combinations, you can see very nice looking waterfall plots where almost every patient is experiencing some element of response. Response rates here in the 30 to 60% range, clinical benefit rate in the 70s, and the median progression-free survival of at least 20 months. And we would expect that with the inclusion of the CDK4/6 inhibitor in this setting. In terms of side effects, imlunestrant is associated with some GI side effects, including diarrhea. And if we combine this with abemaciclib, which also has risks of diarrhea, that's something for us to be mindful of. In the combinations with abemaciclib, there was a rate of all-grade diarrhea that was between 70 to 90%. So almost every patient had some degree of diarrhea, but rate of grade 3 diarrhea was 10% or less. And that would be the toxicity to pay attention to in these types of combinations. So the summary for EMBER is that imlunestrant monotherapy in general is well tolerated with nice post-CDK activity. The drug can be combined with abemaciclib and even with aromatase inhibitor with no new safety signals. And that there are large phase 3 trials that are now ongoing looking at imlunestrant. This includes EMBER-3, which randomizes to imlunestrant, provider choice endocrine therapy, and a combination arm of imlunestrant and abemaciclib post-CDK. So that's actually a CDK after CDK study. And EMBER-4, as we just alluded to, is a very large adjuvant trial with imlunestrant. So if we think about how to put this all into context for hormone receptor-positive disease, in the first-line setting, many of us are giving endocrine therapy with a CDK4/6 inhibitor. But in the second and third-line setting, here's where we have a lot of choices. We can give endocrine therapy with CDK4/6 if we didn't do it already. If there's a BRCA mutation, we can give a PARP inhibitor. We can give an everolimus combination, and that is not mutation selective. But everything else, we need to know the mutation status. If there's a PIK3CA, PTEN, AKT mutation, we have capivasertib, we have alpelisib. If we have an ESR1 mutation, we have elacestrant. And so I think this really, again, supports the need to know tumor genomic profiling as we move down the pathway. So now let's cross over and talk a little bit about antibody drug conjugates, which is a hot area throughout all of oncology and certainly in breast cancer. We have a whole variety of agents that are either approved or under study. I'll first note we have the HER2 targeted agents, the original OG ADC in breast cancer TDM1, and then the next generation agent TDXD, which targets HER2 with a DXD payload. We also have the TROP2 targeting antibodies. This includes sacituzumab, which has the SN38 payload, which is like irinotecan, and a new drug in development, Dato-DXd, which, like sacituzumab, targets TROP2, but has the TDXD payload of DXD. And we're briefly going to touch on patritumab, which is a HER3 targeting antibody that also has the DXD payload. So there's a lot going on in the ADC space. So first, let's review overall survival updates from the TROPiCS-02 study. So we're talking first about hormone receptor-positive, HER2-negative disease. This is pre-treated patients. They'd had at least one line of endocrine therapy. They'd had CDK4/6 inhibitor, and they'd had 2 to 4 lines of chemotherapy in the metastatic setting, or if they rapidly progressed in the adjuvant setting, randomized to sacituzumab or treatment provider choice. And this was CAPE, vinorelbine, gemcitabine, or eribulin. And updated data on progression-free survival continues to show an improvement in PFS from 4 months to about 5.5 months, hazard ratio 0.65, and this is what supported the approval of sacituzumab in this space. Overall survival is positive as well. Patients who received sacituzumab have a median overall survival of 14.5 months, improved over treatment provider choice, which was 11.2 months, hazard ratio 0.79. So about a 20% improvement in overall survival, and this was statistically significant. So extended follow-up of TROPiCS-02 show that improvements in PFS and OS are durable. And that this, there was also some subgroup analysis showing that sacituzumab improved outcomes in subgroups, including depending on TROP2 level, HER2 low, HER2 zero. So all of these patients benefited from sacituzumab. And so, this reinforces that this is an agent for us to consider in endocrine resistant, pre-treated hormone receptor positive disease. Now, we've also seen updates from DESTINY-Breast04. This is a study using TDXD, so targeting HER2, and this was a study that enrolled patients who had HER2 low disease, which means IHC 1 plus or IHC 2 plus and FISH negative. This was a study for patients who had up to 1 to 2 prior lines of chemotherapy in the metastatic setting, and enrolled mostly hormone receptor positive patients, although there was a small population of triple negative patients who enrolled as well, triple negative with HER2 low. And then overall survival updates in both the hormone receptor positive cohort as well as all patients continue to show substantial improvements from about 17 months to about 23 to 24 months, hazard ratio around 0.7. So significant improvement in overall survival, and continued dramatic improvements in progression-free survival from about 4 months to about 9 months. So a highly active agent for these patients. Follow-up on the hormone receptor negative small cohort show results that really mirror what we see in the hormone receptor positive in terms of the benefits gained. Now, we did see updates looking at subgroups, including those with PIK3CA, ESR1, intrinsic subgroup, CDK4/6 resistance, marker status, and across all of these subgroups, we continue to see benefits from the use of TDXD over treatment provider choice. I think it's important to show this data because we do know these things about our patients, although, as we've talked about, knowing PIK3CA and ESR1 is a little more important when we're picking endocrine therapies. By the time we're into chemotherapy, these are of lesser importance, but it's very reassuring to see how broadly across the board TDXD is improving outcomes. And so results of this long-term follow-up of DESTINY-Breast04 show the benefit of TDXD over TPC in HER2 low populations. Benefit is regardless of PIK3CA or ESR1 mutation status, and this has really become our preferred agent in the second line and beyond setting. So first line, we still don't have data from DESTINY-Breast09, which is looking at activity in the first line setting, but for the time being, TDXD lives in the second line setting for our patients with HER2 low disease. If they are not a candidate for TDXD, then we might be considering sacituzumab based on the TROPiCS-02 study. We also saw data from TROPION-Breast01. So this is looking at that new antibody drug conjugate, Dato-DXd, which targets TROP2 but has the DXd payload. This was a study that was in patients with hormone receptor positive disease, pre-treated 1 to 2 prior lines of chemotherapy, but this was not for HER2 low the way we think of for TDXD. This was just HER2 negative. Patients were randomized to Dato versus investigator choice chemotherapy, eribulin, vinorelbine, gemcitabine, or capecitabine. And results of the study showed a significant improvement in progression-free survival, 4.5 months to 6.9 months, with a hazard ratio of 0.64. So definitely a positive study. In terms of adverse events, neutropenia was an adverse event of clinical interest. Not that Dato causes neutropenia, but to show it actually doesn't really cause neutropenia, in contrast to chemotherapy, which certainly does. So we see less neutropenia with the Dato than with chemo. We do know, though, that Dato can cause stomatitis. In fact, there was about half the patients had any grade stomatitis, about 6% with grade 3, and this was a relatively frequent cause for dose reduction. So that is an adverse event that is quite notable for the agent. So Dato improved PFS compared to treatment provider choice in the second and third line setting. We await the more mature overall survival data. There's less neutropenia than chemo, but more stomatitis. There's also some dry eye that you see with Dato. So this could become our 4th ADC approved for breast cancer. And the tricky thing with all the ADCs is to understand how to sequence them. So for example, with sacituzumab, they both target the same receptor. So if we have both available, which one are we going to pick as the preferred agent? And there are trials that are launching now that are looking at sequencing strategies, trying to figure out if we can identify best candidates for one strategy versus another. But we're going to be, if Dato is approved, it's going to be ending up in a very similar place to sacituzumab. So we'll have to figure out how to select one agent versus another. And then we'll move on to the trial of patritumab, which is a HER3 targeting ADC with the DXd payload. This is a study with several parts to it. An initial part of monotherapy in HER2 negative breast cancer. And then part B and part Z, which are currently enrolling, is looking at expansion in groups based on HER3 expression, based on ER expression, and post-TDXD. Now, HER3 is expressed in about 30 to 75% of breast cancers. It's quite common. Overexpression is associated with a poor prognosis, however. And we know that the ADC can target HER3 and brings the DXD payload. So here's the outcome from part A of the study that Erica Hamilton presented this past year. First, if we look on the left, these are swimmers plots looking at outcomes based on HER3 membrane expression. And we can see that there's some patients who are having extremely nice responses to this agent, but the responses are actually seen in all of the categories of HER3 expression. Even patients who have lower expression, there's still those who have, over 6 months of disease stability with the drug. And if we look at the waterfall plot on the right, we can also see that outcomes do not appear to be significantly linked to having higher levels of HER3. So it may not be that knowledge of HER3 itself is necessary, but I think we're going to learn more from the expansion cohorts. And these are the Kaplan-Meier plots for progression-free and overall survival for the patients in the study. Again, showing that all of the subgroups of HER3 expression are having improved outcomes or having nice outcomes with this agent. The safety profile is notable for nausea, fatigue, diarrhea, many of the things that we tend to see with the DXD targeting ADCs. But patritumab is active regardless of level of HER3 expression. These responses appear to be durable. And I'll point out that there's very little ILD to date, which is also very favorable given what we've seen with TDXD. But again, it's unclear how many patients would respond to this drug after prior treatment on TDXD or even Dato-DXD. And figuring out how to sequence the ADCs and how this drug in particular would fit into the sequence is tricky as well. So that's going to unlock a whole new generation of clinical trials for us looking at these sequencing strategies. So this brings us to the end of our updates from 2023. It's quite a whirlwind. And I think, as you see, there's a lot of new data, a lot of new agents, some great new agents that are helping our patients today, but a lot of questions that come up about how to insert these into our treatment paradigms and how to pick best candidates. So I very much look forward to 2024 and hope that we're going to see a lot more discovery and development that will continue to refine our portfolios and paradigms for our patients.
So that was awesome. Just two quick follow-up questions. I'm curious to what extent you've had any experience with Dato and how you find mouthwash prevention.
So thank you. That we do have Dato available in our clinical trials, and the mucositis is real. And we are instructing patients to use the prophylactic steroid mouthwash, the same one that we use with everolimus. If we think back to the old Swish study that Hope Rugo led, that was so successful in showing us that prophylactic steroid mouthwash prevents mucositis. It's a wonderful tool that we can really expand to use for other drugs that cause mucositis. So it is something that is included in ongoing Dato protocols.
But have you yourself seen that it works?
It does work. And so patients do use it and they have less mucositis. I will say that, some toxicities we see with cancer therapies occur in the beginning. And once you get over the hump, then you can kind of taper off your prophylaxis. It's not clear what the timing and kinetics of the mucositis toxicity is, whether it's just in the beginning and then you could taper off, or whether it's something where a patient would need to continuously be using the mouthwash. We offer the mouthwash. We tell people to use it 4 times a day. That's a lot. And so, it's nice when you can get over the hump and then taper down. And we don't know yet what the rhythm will be with Dato.
Yeah, we're getting a lot of questions from the lung people about this. So do you find that the mouthwash is similarly effective as it is with, say, everolimus?
I definitely think that it helps treat and manage mucositis. It's not going to make grade 3 mucositis go away. That may require dose reduction, but it definitely can delay the appearance of mucositis and diminish the seriousness of the mucositis. So it's a very helpful tool to have available.